Hi everybody, my name is Whitney Gibson. I'm a critical care pharmacist, and today we will discuss the use of therapeutic coma for refractory status epilepticus. I have received a speaker's fee for the presentation, but I have no other conflicts of interest to disclose. The objectives we'll discuss today are to recall the pathophysiology and etiology of refractory status epilepticus, to identify monitoring targets and goals of therapy for pharmacologic agents used for status epilepticus, to explain the role of continuous infusion sedatives in the treatment algorithm of refractory status, and to review available pharmacologic continuous infusion options and dosing strategies for the treatment of refractory status epilepticus. So first, we'll dive into a brief overview. An estimated 50,000 to 200,000 cases of status epilepticus per year have been reported. The mortality rate varies between 9 and 61% depending on the class and seizure duration. Guidelines have done away with assigning a time to the definition of refractory status. There are two guidelines, one published by the American Epilepsy Society and the other by the Neurocritical Care Society. In general, status epilepticus is considered greater than or equal to 5 minutes of continuous seizure activity or recurrent seizures without recovery of consciousness. Refractory status is defined by continued clinical or electrographic seizures despite receiving adequate doses of an initial benzodiazepine followed by acceptable anti-epileptic drugs. The mechanisms of seizures can be fairly complicated, but I'll break it down here in a much simpler sense. So essentially, there is either a failure to inhibit excitatory neurons or decreased firing of inhibitory neurons. So our excitatory neurons, we think of glutamate, calcium, sodium, substance P, and neurokinin B. Our inhibitory neurons are GABA, adenosine, potassium, neuropeptide Y, and opioid peptides. Now, there are several etiologies that could lead to refractory seizures or seizures alone. In the ICU, we typically think of CNS infections, stroke, acute head trauma with or without hematoma, but we also do consider drug toxicities, seizures after cardiac arrest, patients with autoimmune encephalitis, septic patients, and then there's also patients with more chronic processes that lead to seizure, like chronic alcohol abuse, and other CNS pathologies. Regarding a diagnosis, in all patients that come in with status epilepticus, we need to get a point-of-care glucose test, closely monitor their vital signs, and get a head CT. Also, we want to get the normal labs that we would get, their CBC, their BMP, calcium, magnesium. And if there are anti-epileptic drug levels and they are on these medications, it's important that we get those levels as well to monitor for toxicity. You can also consider things like brain MRI, a lumbar puncture, toxicology panels, as well as other tests like liver function tests, troponins, coagulopathy studies, getting an ABG, and other screens as well. It's important to note, since there are the two different societies that have guidelines, American Epilepsy Society and Neurocritical Care Society, the verbiage of what they call the different phases of status epilepticus are called different things, but they mean the same thing as far as timing. So the American Epilepsy Society's verbiage is on top and Neurocritical Care Society's is on the bottom. So 0 to 5 minutes of status epilepticus is considered the stabilization phase. 5 to 20 minutes, you have your either initial therapy phase or emergent initial therapy, depending on which guideline you're reading. 20 to 40 minutes is the second therapy phase or urgent control therapy phase. And then 40 to 60 minutes can either be called the third therapy phase or refractory therapy. Overall, both agree that definitive control should be established within 60 minutes of onset. It's important just to note that there are evidence rating systems based on American Heart Association and American College of Cardiology guidelines to help us look at the literature and its strength and level of evidence. Generalized seizure activity impairs mental status and the ability to protect an airway. So the airway should always be assessed concurrently with initial AED administration and should be serially evaluated as therapy is escalated. Just like with any good critical care, we're going to look at our ABCs first: airway, breathing, circulation, and then getting the labs that we need. All of this would be in the stabilization phase while we're starting initial therapy. Also in the stabilization phase, we have, again, our critical care treatment and our goals of therapy. So the guidelines do give timing recommendations in the stabilization phase, really within the first handful of minutes. So again, airway protection, making sure the adequate gas exchange is happening and that the head is positioned well, intubating our patients if they're unable to protect their airway, close monitoring of vital signs, trying to avoid hypotension when possible, so your patients may need vasopressor support, getting a point of care glucose to make sure that we're not missing hypoglycemia, and getting peripheral IV access for antiepileptic therapy, for fluids, and nutrient administration. Some patients may need thiamine, they may need dextrose. During the stabilization phase, we are also looking at urgent control with antiepileptics to stop the immediate seizure, a good neurologic exam to evaluate for mass lesions, any acute intracranial process, triaging their labs to make sure we're not missing a life-threatening metabolic condition, and then thinking about refractory status treatment if initial treatments are not stopping the seizure. We may also want to get urinary catheter in place to evaluate their circulation, make sure that their urine output is adequate. It's also a good idea, wherever available, to place a continuous EEG on our patients, as we know not all patients will exhibit physical symptoms of seizures. And then diagnostic testing, as we discussed before. Next, we have the emergent initial therapy phase. So this is where we continue our supportive care, plus we're continuing to give benzodiazepines such as lorazepam, midazolam, diazepam. We're also considering other antiepileptics like phenytoin, phenobarbital, valproate, and levetiracetam. If the patient is taking an AED at home, it's reasonable to reload or bolus that AED, and this is where we're moving into the urgent control therapy. They may have missed doses, their doses may no longer be adequate. This is also where drug levels come into play, considering valproate and phenytoin, levetiracetam. Not everyone can get levels of this drug, but if it's available at your hospital, that is something to consider. This is also usually where we're going to start a midazolam continuous infusion. So as we move on to the refractory therapy phase, this is where we will focus the majority of our presentation time. So it's a good idea to place continuous EEG monitoring at this point if it's available in your hospital, because we still need to determine if the status epilepticus is continuing despite our previous therapies. Again, not all patients are going to exhibit the physical symptoms. This is also where we think about if we're going to repeat bolusing of the agents that we already have on board, or if we're going to dive into therapeutic comas. For the purposes of the remainder of this presentation, we'll focus on therapeutic coma with midazolam, propofol, and pentobarbital. Up to 43% of status epilepticus patients will experience refractory status. Mortality has been estimated to be as high as 61%. The likelihood of returning to baseline conditions after non-refractory status is 63 versus 21% with refractory status epilepticus. One study showed among survivors at discharge, 62% were disabled, 23% in a vegetative state, and 15% were independent but moderately disabled. There are a few risk factors to consider that indicate poor outcomes in these patients. Being over the age of 52, having a longer seizure duration, high Apache 2 scores, which indicate severity of illness, if it's caused by a large ischemic stroke or hemorrhage, if there is a central nervous system or systemic infection, a malignant brain tumor, or eclampsia. So we'll talk a little bit about continuous EEG. I just want to touch on it briefly. This measures spontaneous electrical activity in the cerebral cortex. Electrical currents that flow into extracellular spaces are what are picked up on the EEG reading. And the EEG reading will also show you voltage versus time graphs. Each channel will represent a difference in electrical potential between the two electrodes. Typically, the leads are placed in different areas of the head, and this one is showing you the difference between normal background activity on the right and an absence seizure on the left. The electrodes measure the movement of action potentials. The action potentials moving towards an electrode make a positive waveform deflection, so the line will go up. If moving away from the electrode, the line goes down. The waveform means that there are action potentials moving towards and away from the electrodes. We have pacemaker cells in the thalamus that produce a rhythm of action potentials at baseline related to different brain states, which produce different waveforms. For example, an alpha wave could be you're very relaxed, very focused. Beta waves are more alert, and delta waves are where we see deep sleep. One debated thing in the literature for therapeutic coma are the goals. So are we looking for electrical suppression of seizure activity? Are we titrating to a burst suppression pattern? Are we looking for full suppression of EEG activity? These are important goals to discuss with your physician to make sure that everybody's on the same page of what we're titrating towards. Burst suppression is normally the goal. So bursts of abnormal discharges, spikes or sharp waves, represent epileptiform activity. During status epilepticus, there are repeated spike wave discharges. So now you say, well, what is the target burst suppression goal? Again, this is something you and the provider need to establish. There is not a hard and fast goal for burst suppression, but typically we are going to suppress to anywhere from 1 to 6 seconds of burst suppression. And this is what it'll look like on the EEG. So you'll see the burst, you'll see the period of suppression, and I have them numbered here. So this would be an example of 6 seconds of burst suppression. Common recommendations are anywhere from 4 to 10 seconds for 24 hours. I typically in practice see somewhere less than 6. The controversy is that there's no association between a specific target and better outcomes. There's very mixed data. Some studies have shown no benefit to suppressing to a specific number of bursts. There is an association between therapeutic coma and worse outcomes, but this may not be an association saying that putting somebody on therapeutic coma for burst suppression gives them a worse outcome. It's likely that if they reach the point of needing a therapeutic coma, they are already set up for worse outcomes. There are many complications, such as hypotension with higher infusion rates, and the burst characteristics and overall duration of suppression may be more predictive of successful titration versus your target bursts. So here are pharmacotherapy options for refractory status. The options in blue are other options for refractory status, but are not the focus of this presentation. You will likely already see your patients on these, or they may be added onto therapy even after your continuous infusions have started, and that is okay. We're doing everything we can to get these patients to stop seizing. So we'll start with midazolam or Versed. It binds to GABA receptors, the major inhibitory receptor within the central nervous system. This results in opening of the chloride channels caused by hyperpolarization, decreased excitability of neurons, and has a calming effect on brain activity. Levels may be affected by AEDs and other medications, which may be inducers or inhibitors of the CYP3A4. It is renally eliminated, so it may accumulate in patients with renal dysfunction, which normally if you're using for normal sedation, this is something that we would worry about. However, in this patient population, this is a very successful drug for burst suppression, so we won't be too worried about that kinetic profile. Now we'll get into the dosing of midazolam. You'll notice the biggest difference is that for refractory status and burst suppression, your dosing is going to be weight-based. Don't be afraid of the high doses. These are needed for burst suppression. So your continuous infusion dosing will be anywhere from 0.05 to 2.9 milligrams per kilo per hour. 2.9 is considered the max dose. For breakthrough dosing, they can consider giving boluses of 0.1 to 0.2 milligrams per kilo, and it's recommended to increase the rate by 0.05 to 0.1 milligrams per kilo per hour every 3 to 4 hours. We do need to watch out for respiratory depression. However, the patients are intubated, so this is negligible. But we do need to watch out for hypotension. Typically with all of these agents, you want to go ahead and have a pressor ready and on board because they will likely make patients hypotensive at these large doses. Some pearls to consider. Midazolam does not contain propylene glycol. This means less risk of hypotension and less risk of metabolic acidosis that has been attached to lorazepam or Ativan dosing. Tachyphylaxis can occur after prolonged use, which will necessitate progressively higher doses to achieve the same effect. There is increased half-life after prolonged duration because midazolam does have so many metabolites. It is very lipophilic, and the free fraction will increase at steady state. Case reports have also demonstrated significantly increased half-life after prolonged infusion due to the increased free fraction and volume of distribution and accumulation of the active metabolite, leading to longer than expected time to awakening after stopping infusion. This is something that you really need to think about because if these patients get to a point where the provider or the family thinks that treatment is futile and they want to start looking at something like a brain death exam, we have to consider how long the drug is going to stay in the body before they can truly say that the patient is off of the drug, and that could be affecting neuroexam. The lipophilic nature of midazolam at physiologic pH levels produces rapid absorption and enhanced penetration into the CNS. Next, we'll discuss propofol. Propofol is an agonist of GABA A receptors, sodium and calcium channel blockade action, and also has proposed antagonism of NMDA receptors. The oil and water emulsion allows for rapid CNS distribution and a near immediate onset of action. It does have quick redistribution into peripheral tissue, as well as increased clearance. Initial elimination is 40 minutes. However, this is biphasic, especially at larger doses, and depends on your volume of distribution. So elimination could take up to 1 to 3 days in prolonged use. Especially this has been found after 10-day infusions. Again, we will see much higher doses of propofol used. Don't be afraid of these doses, they are necessary. You could see 30 to 200 mics per kilo per minute. That is the standard accepting dosing range. You can also bolus in this disease state, although it will produce hypotension. However, this is an expected side effect of all of these agents. Like I said, it will produce hypotension, have a vasopressor on board. Respiratory depression is negligible because they are intubated. High doses of propofol have been linked to cardiac failure, so that's something we want to look out for, rhabdomyolysis, metabolic acidosis, and typically PRIS is something that we don't worry about with propofol. It is considered to be very rare. However, at these doses and at the length of therapy that we're expecting, we do need to be monitoring for this. So our pearls for propofol, its mechanism of hypotension includes inhibition of sympathetic nerve activity, which directly reduces our systemic vascular resistance and decreases myocardial blood flow. You likely will need a vasoactive on board. When we're thinking about monitoring for propofol-related infusion syndrome or PRIS, we monitor for rhabdomyolysis. You may need to get a CK level, myocardial failure, renal failure, hepatomegaly, hyperkalemia, and hypertriglyceridemia. The risk is considered at higher rates of propofol and used for greater than 48 hours, which we will definitely meet those risk factors with this dosing. We do need to monitor triglycerides. I would recommend twice weekly and then weekly thereafter, depending on how long the patient is on this infusion. And consider with nutrition, we must adjust the daily caloric intake. Our next agent is pentobarbital, and this is an agonist of GABA-A, just like propofol, and an NMDA antagonist. It prolongs the opening of chloride channels. It will induce complete suppression of cerebral activity. This is really considered our big gun agent. Some interactions to consider. Valproate will decrease barbiturate metabolism, so it may increase pentobarbital concentrations, but that's okay. That just means we may not need to use as much pentobarbital if they are on valproate. Also consider that pentobarbital will lower lamotrigine concentrations, so if you're able to get levels, get them and adjust accordingly. If not, you may want to consider empirically adjusting lamotrigine. Again, here we see weight-based dosing of our continuous infusion, 0.5 to 5 milligrams per kilogram per hour. There's also breakthrough bolus dosing, which is appropriate. We're going to see hypotension, respiratory depression, and some cardiac depression. You do want to look out for a paralytic ileus, especially at these high concentrations. This doesn't mean that you can't feed these patients, but we do need to monitor their residuals if you're feeding enterally. There is also complete loss of neurologic function. Pentobarbital can cause immunosuppression as well as gastric paresis. We do need to monitor these patients really closely. Again, hypotension is very common. It will reduce intracranial pressure, which is great if we're using for something like traumatic brain injury. It has great penetration into the CNS. What we really need to focus on with pentobarbital is the half-life. So the half-life of pentobarbital is dose and patient dependent and varies from 15 to 50 hours with just an IV bolus. It has a huge distribution into the brain, liver, and kidneys. This is the one that's most complicated to discuss when the family decides they want to proceed with a brain death exam. Depending on how long your patient has been on this continuous infusion, it could be days, upwards of a week or two before this drug is no longer on board after it's stopped. So that's something we really need to consider to ethically complete the brain death exam. Additionally, it does contain propylene glycol, which likely does contribute to the hypotension. It is highly lipophilic and is associated with elevated rates of ventilator-associated pneumonia. So some final thoughts. Make sure the current AEDs on board are maximized and that those with levels are therapeutic if you're able to get those levels. You may see orders for higher doses of these agents than you're used to seeing, but this is by design. Identifying and treating the underlying cause is always important. If the infection is driving the refractory status, we need to treat the infection. Patients will likely need a vasopressor on board. I know I've said this about 100 times so far, but don't avoid these agents because of the hypotension that ensues. Communicate with your neurology team or your primary care that's driving the use of these agents to obtain their goals of care. Always monitor for interactions and side effects of each agent. And you do need to communicate with your IV room and your purchasing team. Some of these agents are not always available. With thiopental and pentobarbital, those companies do highly regulate how much of their product is released to each hospital, each country. So we need to make sure before starting these agents that we have enough for prolonged use because we expect that so that there are no interruptions in therapy. That is a very brief overview of the use of therapeutic coma for refractory status epilepticus. Thank you so much for your attention.